There's a woman sitting in an endocrinologist's office. She's been on Tirzepatide for 11 months. She's doing everything right: the protein, the walks, the injections every Thursday morning without fail. And she's lost weight, 14% of her body weight, which her doctor calls a success. But her friend, same age, same BMI, similar history, started the same medication 8 months ago. Her friend has lost 22%. Same drug, same dose range, completely different result. And when this woman asked her doctor why, he shrugged. That shrug is what this video is about, because there's a hidden step that determines how well tirzepatide works in women after menopause, and most doctors aren't asking about it. Not because they're careless, because the research connecting these two things was only published in January of this year, and it changes everything. Before we go further, this is education, not medical advice. Everything I share today comes from peer-reviewed research. Your decisions about medication should always be made with a doctor who knows your full history. My name is James. This channel exists because there's a gap between what the research says and what most people hear in a 15-minute appointment. I read the studies so you can walk into that room with better questions. That's the only credential that matters here. Before I tell you what that hidden step is, I want to know where you are right now. Drop your age in the comments, just the number, because what I'm about to share hits differently depending on where you are in this transition. Here's the problem with how menopause and obesity are treated in the American medical system. They are treated as two separate problems. You see your gynecologist for the menopause, you see your endocrinologist or primary care doctor for the weight. And if you're on a GLP-1 medication like tirzepatide, your prescribing physician is almost certainly focused on one thing: the number on the scale at your last appointment. Nobody is in the room asking the question that a team at the Mayo Clinic finally thought to ask. The question is, what happens when you combine tirzepatide with menopausal hormone therapy? Nobody told you to ask that. Nobody told you that. Here is what we know. Menopause is not just a reproductive event. When estrogen drops, and it drops sharply, usually between your late 40s and early 50s, your body's entire metabolic architecture shifts. Abdominal fat increases, lean muscle mass decreases, resting energy expenditure falls, and your sensitivity to the appetite-suppressing signals your own body produces, including GLP-1, the exact hormone that tirzepatide mimics, may be reduced. The same hormonal shift that makes you gain weight after menopause may also make the drug you're taking to lose that weight less effective. The condition that drives you towards tirzepatide may be blunting tirzepatide's ability to work. This is not a coincidence. This is biology. A team at the Mayo Clinic and Wayne State University decided to find out what happens when you address both sides of that equation at the same time. What they found, published in the Lancet Obstetrics, Gynecology, and Women's Health in January 2026, is the reason you're watching this video. Women who were using menopausal hormone therapy while taking tirzepatide lost 35% more weight than women taking tirzepatide alone. 35%. Not a rounding error, not a marginal improvement. 35% more weight lost in a real-world study of postmenopausal women tracked for an average of 18 months. So the question isn't, does tirzepatide work? The question is, are you getting everything tirzepatide can give you? For millions of postmenopausal women, the honest answer, based on this data, may be no. In the next few minutes, I'm going to walk you through exactly what the Mayo Clinic researchers found, the numbers, the methodology, and the biological hypothesis that explains why this combination may produce results that neither treatment achieves alone. Stay with me. Let me tell you exactly what the Mayo Clinic researchers did, because the design of this study matters. They didn't run a clinical trial with a controlled intervention. They did something more honest for this stage of the research. They went into real medical records. They pulled data from the Mayo Clinic health system. 15,639 women with active tirzepatide prescriptions. From that pool, they identified 120 postmenopausal women who fit their criteria. Overweight or obese, on tirzepatide for at least 12 months, no confounding variables that would make comparison impossible. Then they divided them. 40 women were using menopausal hormone therapy alongside their tirzepatide. 80 were not. And they used a statistical method called propensity score matching to make the two groups as comparable as possible. Same age range, similar BMI, similar menopause history. They tracked them for an average of 18 months. The result? Women using tirzepatide alongside hormone therapy lost an average of 19.2% of their total body weight. Women using tirzepatide alone lost 14%. That's the 35% difference. Not 35 percentage points, 35% more relative weight loss. The hormone therapy group didn't just do better, they did dramatically better. And then there's the number that stopped me cold when I read it. 45% of the women using both tirzepatide and hormone therapy achieved more than 20% total body weight loss. In the tirzepatide-only group, that number was 18%. Think about what that means in practice. If you put 100 postmenopausal women on tirzepatide without hormone therapy, about 18 of them will lose more than a fifth of their body weight. Add hormone therapy, and that number jumps to 45. That is not a small effect. Now, the researchers were careful about what they could claim. Dr. Maria Daniela Hurtado Andrade, the senior author of the study, said it directly. Because this was an observational study and not a randomized controlled trial, they cannot say that hormone therapy caused the additional weight loss. Is associated with is not the same as causes. The difference is real, and I'm not going to gloss over it. But here's what I think, and I want to be clear, this is my interpretation, not the researchers' conclusion. The magnitude of this difference is too large to dismiss as noise. A 35% difference in weight loss outcomes replicated across 120 real patients tracked for 18 months, with a secondary finding that more than twice as many women in the hormone therapy group crossed the 20% threshold. That is a signal worth taking seriously. The researchers agree. They're already planning a randomized controlled trial to confirm it. So why might this combination work? The researchers offer two main hypotheses. The first is the healthy user effect. Women on hormone therapy may be simply more engaged with their overall health, more likely to follow dietary guidance, exercise consistently, show up to follow-up appointments. In that case, the hormone therapy is creating the conditions under which tirzepatide can do its job. The second hypothesis is more mechanistic and more interesting. Preclinical studies in rodents have shown that estrogen may directly enhance the body's natural GLP-1 signaling system. GLP-1, glucagon-like peptide 1, is the hormone that tirzepatide mimics. If estrogen amplifies that signal, then replacing the estrogen that menopause took away might restore the biological conditions under which tirzepatide reaches its full effect. Tirzepatide may be a more powerful drug in an estrogenic environment. Your body after menopause, lower estrogen, altered GLP-1 sensitivity, may be working against the medication before it even has a chance to work. Drop a comment right now. Tell me, is your doctor aware that you're on hormone therapy or not when they're managing your tirzepatide? Just write yes or no. I want to know how many of you are being treated as one whole person and how many are being managed in separate silos. Because knowing the number is one thing. knowing what to do with it, the exact words to bring into your doctor's office in both scenarios so you can have a different conversation at your next appointment is something else entirely. That's what's coming next. Write this down, because what I'm about to walk you through is the part that no other video on this topic has delivered. The study exists, the headlines exist. What doesn't exist until right now is a clear explanation of what is actually happening inside your body and the exact words you need to say to your doctor to make this conversation happen. When estrogen drops at menopause, the signaling environment throughout your body changes simultaneously. In your hypothalamus, the part of your brain that regulates hunger and energy balance, estrogen normally helps calibrate appetite. Without it, the hunger-suppressing signals your body sends become harder to detect. You're not imagining that food feels more compelling after menopause. Your brain's sensitivity to satiety signals is genuinely reduced. Now add GLP-1 to that picture. GLP-1 is a hormone your gut produces naturally after eating. It signals to your brain, slow down, you've had enough. It also slows the rate at which food leaves your stomach, and it improves your cell's ability to respond to insulin.
For some women, those with personal or family histories of hormone-sensitive cancers, blood clots, or cardiovascular conditions, it may not be appropriate at all. For others, the risk-benefit calculation depends on factors that only you and a physician who knows your complete history can evaluate. I am not telling you to start hormone therapy. I am telling you that if you are a postmenopausal woman on tirzepatide who is not achieving the results you expected, this research gives you a specific, evidence-based question to put in front of your medical team. I also want to address the women already on both medications who wonder why their results don't match the studies. Hormone therapy is not one size fits all. The type of estrogen, oral versus transdermal, affects how it is metabolized and how it interacts with other systems. The dose matters. The timing relative to menopause onset matters. Women who begin hormone therapy closer to the onset of menopause, within the critical window, roughly the first 10 years, appear to derive greater metabolic benefits than women who begin it later. A recommendation is not a verdict. The initial prescription your doctor wrote is a starting point, not a final answer. Your body at 52 is not your body at 48. Your hormonal environment is not static, and the medications you're taking interact with that environment in ways that are only now beginning to be mapped. Here is what I want you to walk away with today. 3 things. Write them down. 1. If you are a postmenopausal woman on tirzepatide and not on hormone therapy, ask your doctor specifically about the January 2026 Lancet study. Use the exact language I gave you. Don't paraphrase. The precision signals that you've done real research. 2. If you are already on both medications, ask whether your hormone therapy formulation and dose are optimized, not just present. Being on hormone therapy and having it calibrated are not the same thing. 3. If your gynecologist and your prescribing physician are not talking to each other about these 2 treatments simultaneously, you may need to be the bridge. Bring a printed summary of your medications to both appointments. Ask each provider directly, "Are you aware of my full medication list, and have you considered how these treatments may interact?" You are not a passive recipient of medical decisions. You are an informed participant in your own health. And the difference between those 2 identities for women navigating menopause and obesity simultaneously in a healthcare system that was not designed to treat them as one connected problem is maybe exactly 35%. Drop the word informed in the comments right now if you're walking away from this video ready to have a different conversation with your doctor. I read every single one. And if you know someone, a friend, a sister, a colleague, who's been on tirzepatide for months and feels like the drug is letting her down, like she's doing everything right and the results still aren't there, She needs to see this before her next appointment. Send it to her now, not later, now, because the gap between what this research shows and what reaches the average patient doesn't close by itself. It closes one conversation at a time. The researchers at the Mayo Clinic are already planning the randomized controlled trial to confirm what this observational data suggests and to find out whether the benefits extend beyond weight loss to cardiovascular risk, blood pressure, triglycerides, and insulin sensitivity. That trial will take years. The results won't be available tomorrow. But the question it's asking, whether treating menopause and obesity as one connected biological event produces better outcomes than treating them separately, is a question you can start asking your own medical team right now. Don't wait for the trial. Start the conversation. And if you want to go deeper on the science of menopause and metabolic health, on what the evidence actually says versus what most appointments deliver, subscribe and stay close. That is exactly what this channel is built for. This is not medical advice. The information in this video is for educational purposes only. Always consult a qualified healthcare provider before making any changes to your medications or treatment plan. Individual results vary, and the research discussed today reflects findings from an observational study that has not yet been confirmed by a randomized controlled trial.
Tirzepatide, sold as Zepbound for weight management and Mounjaro for type 2 diabetes, is a dual agonist that activates both GLP-1 receptors and GIP receptors. It's the most effective pharmacological weight loss tool available, producing average weight loss of around 20 to 22% of body weight over 72 weeks in clinical trials. The preclinical data suggests that estrogen doesn't just coexist with GLP-1 signaling, it may actively enhance it. Animal studies have shown that estrogen treatment can upregulate GLP-1 receptor expression, meaning more receptors available to receive the signal that tirzepatide is sending. When estrogen is low, those receptors may be fewer, less sensitive, or both. If that mechanism holds in humans, and the clinical data from this study suggests it might, then the woman taking tirzepatide after menopause without hormone therapy is running a race with a weight on her ankle that she doesn't know is there. And her doctor may not either. This is not a criticism of any individual physician. The Lancet paper was published in January 2026. Most clinical guidelines take years to incorporate new evidence. Your doctor is working from a framework that was built before this data existed. That is the gap. That is what you are here to close. There are two scenarios. Either you are on tirzepatide and not on hormone therapy, or you are on tirzepatide and already using hormone therapy. The conversation is different in each case. Scenario 1. You are on tirzepatide and not on hormone therapy. The question to ask is not, should I be on hormones? That's too broad and will get you a broad answer. The question to ask is this. I recently read a study published in the Lancet in January 2026 showing that postmenopausal women on menopausal hormone therapy lost 35% more weight than tirzepatide alone. They were also more than twice as likely to achieve more than 20% total body weight loss, 45% versus 18%. The question to ask is this. Given my history and current results, is hormone therapy something worth evaluating in my case? That question does three things. It cites a specific source, it frames the conversation around your results, not a general preference, and it invites your doctor into a clinical discussion rather than putting them on the defensive. Write that question down, word for word if you need to. Bring it to your next appointment. Scenario 2, you are already on both tirzepatide and hormone therapy. Ask, Given what we now know about the potential interaction between estrogen levels and GLP-1 sensitivity, is my current hormone therapy dose and formulation appropriate for supporting the best possible outcomes on tirzepatide? That is not a question most women are asking. It signals that you understand the mechanism, and it may open a conversation about optimization that your results depend on. This is precisely the situation where the silo problem becomes the most dangerous. Your gynecologist manages your hormone therapy. Your endocrinologist or primary care physician manages your tirzepatide. Unless those two providers are actively communicating, and in most American healthcare systems they are not, the question of how these two treatments interact will fall through the gap between their offices. You may need to be the person who carries the information from one room to the other. That is not fair. It is also reality, and knowing it puts you in a position to act on it. In my view, treating menopause and obesity as separate problems managed by separate specialists without any coordination around their potential interactions is one of the most significant gaps in how we care for women in midlife right now. The research is pointing towards a more integrated approach. The healthcare system hasn't caught up yet. That gap is where this channel lives. Let's talk about what we actually know and what we don't, because you deserve both sides of this picture. What we know, a real-world study of 120 postmenopausal women tracked for 18 months found that the group using menopausal hormone therapy alongside tirzepatide lost 35% more weight than the tirzepatide alone. They were also more than twice as likely to achieve more than 20% total body weight loss, 45% versus 18%. What that means for you, this is not a prescription. This is a conversation starter. The data is strong enough to bring to your doctor. It is not strong enough to act on alone. Hormone therapy carries its own risk profile.